in the gray area of any emergency kit. This is the composition of the emergency kit, which should be provided to the patient after the acute episode. And steroids are really in the gray area, as their administration can even delay the prompt administration of adrenaline. So antihistamines don't work fast enough, and you have here the time to 50% suppression of histamine-induced flare of two types of antihistamine, and here steroids again don't work fast enough, and we have from 30 minutes to 120 minutes, which is too long for a patient experiencing anaphylaxis in 10 minutes, 30 minutes. When the patient has recovered from the acute episode, should be closely monitored for at least 6-8 hours, especially in patients with respiratory compromise. And this observation should be extended in patients presented with a circulatory cardiovascular collapse, which require close monitoring for 12 to 24 hours. Before discharge, the risk of relapse should be assessed, and an adrenaline autoinjector should be prescribed. For those at risk of recurrence, should be always prescribed, I would say. Patient should be provided also with discharge advice sheet, including allergen avoidance measures, where possible, and instruction for the correct use of the adrenaline autoinjector. Specialist and food allergy specialist dietitian in food anaphylaxis follow-up should be organized, and contact information for the patient support groups should also be provided. What is the role of adrenaline autoinjector? Actually, autoinjectors are automatic devices which were developed in the late 60s by U.S. Army as relievers for the war with the nerve gas. And these automatic devices are intended to emergency first aid treatment of anaphylaxis that can be administered rapidly, safely, and intramuscularly with very rapid absorption, and represent the currently the preferred mean of achieving an accurate dose, as they provide a prefined dose of intramuscular adrenaline, preventing overdosing. They are intended for the use in high-stress medical emergencies, where when you are in a panic, you can have a mistake in the dose of adrenaline, and where treatment failures and accidental needle stick injuries can be reduced to a minimum. And I've also those fixed for children. International guidelines do not consider anymore adrenaline ampoule syringe suitable for, especially for non-medical setting. Adrenaline infusion, IV infusion, must be given only by those experienced in the use of vasopressor in their daily clinical practice. Patients should be given intravenous adrenaline only in equipped setting under close monitoring of the continuous electrocardiogram, pulse oximetry, and frequently non-invasive blood pressure. Intravenous adrenaline, there are benefits from autoinjector compared to adrenaline ampoules syringe. Dosing mistakes are very uncommon with the predefined dose compared to syringe. The risk of administering a fixed dose is considered lower than the risk of dose error in adrenaline ampoule and syringe. And here you can see the time to drop the dose in parents, physician, nurse in emergency department. There is a significant length of time for parents compared to a professional. Nevertheless, the adrenaline dose variability is not correct for all the categories. It's 40-fold for parents, but it's 6-fold for physician, nurses, a bit better, but even 2-fold mistakes for the nurses in emergency department. So failure to inject adrenaline promptly can lead to fatality, encephalopathy because of hypoxia and ischemia, and biphasic anaphylaxis. So we should act rapidly as anaphylaxis progresses rapidly and can be fatal within minutes. We know that the median time of cardiac respiratory arrest is 5 minutes for iatrogenic, 15 for venom, and 30 minutes for food. In pharmacokinetic studies performed upon European Medicine Agency request on all the auto-injectors in the market, EpiPen administered in the mild type provides the highest adrenaline exposure. And you can see here the plasma concentration after administration of EpiPen or syringe at the mid-anterolateral or distal anterolateral tie. And here with the EpiPen at the mid-anterolateral tie, we have the maximum concentration, the peak max at 20 minutes, while it is 25 at distal tie and 50 minutes of the syringe. So EpiPen provides a more effective and rapid adrenaline delivery compared to a syringe. Likewise, in a study performed by EMA request on all the auto-injectors, EpiPen provides the highest adrenaline exposure. And highest adrenaline exposure with EpiPen mid-type, superior adrenaline exposure with EpiPen mid or distal type versus syringe, and reduced and delayed adrenaline exposure with syringe despite optimization of the needle length. So in conclusion, the Tmax is 0.25 faster with EpiPen versus syringe, and the maximum concentration is more than 30% higher with EpiPen versus syringe. So more effective and rapid adrenaline delivery with EpiPen compared to syringe again. And similar exposure to adrenaline was noted in all groups. Why to auto-inject? A single dose of adrenaline is not always sufficient, and we know from previous studies that reaction where initially intramuscular adrenaline was not sufficient happened in 32% of cases according to the series until 18% of cases. So there is a huge proportion of the population of patients experiencing anaphylaxis which doesn't respond to the first dose. And this may not be enough, as we can have a severe protracted anaphylaxis symptoms or biphasic reaction, rapid anaphylaxis suppression, delaying adrenaline injection, adrenaline may be expired, or the injection site is not optimal, or under a panic situation, we don't administer correctly the injection. The dose can be too low based on milligram per kilogram basis, and maybe concurrent medication interference. So, two auto-injectors should be provided as about 30% of patients who develop anaphylaxis, as about 30% will require probably another dose of adrenaline. Biphasic reaction develops out of the patient, and that can be more severe than the initial one. Typical, of course, 4 to 12 hours from the first symptoms on signs, and it is increased according to the prospective studies by delaying giving adrenaline or insufficient first dose adrenaline. Getting in real world daily practice, I would like to illustrate to you this clinical case where a 17-year-old girl with unstable asthma and food allergy to fish and shellfish, living in remote rural setting with elderly patient parents, experienced symptoms typical of anaphylaxis after applying a lipstick. She developed swollen lips, throat, localized hives, and respiratory stress. She self-administered the intramuscular adrenaline, 0.3 milligram. She phoned ambulance, and the reply was that response to her location would have taken more than 20 minutes. After 5 minutes, the symptoms were not better, maybe worse, so she administered the second dose. When she presented at the hospital, approximately 40 minutes for anaphylaxis, symptoms were going better. Hives were evident, but there was a mild wheezing. So she received only nebulized albuterol and had careful observation for 6 hours. And the outcome, she received a prescription of auto-injector and advice for avoiding allergy. So in summary, this clinical case provides you with the main reasons for 2 auto-injectors, being a patient at high risk, suffering from unstable asthma and food allergy, and living at distance from medical care. So, at the end, as a summary of all this brief overview, I would like to remind you that intramuscular adrenaline is the first-line treatment for anaphylaxis. In case of anaphylaxis, immediate treatment for auto-injector can be life-saving, especially when administered by non-medical people. Anaphylactic patients and people at risk should be always prescribed with 2 auto-injectors that they should carry at all times. And this is the recommendation of the European Medicine Agency, which is as valid in all European countries. So I would like to take your questions, and thank you very much for your attention.